Hey students, you're listening to the recorded lecture for management of patients with dysrhythmias and conduction problems. The objectives for this lecture are for you to be able to correlate the components of the normal ECG with physiologic evidence of the heart, define the ECG as a waveform that represents the cardiac electrical event in relation to the lead that you're looking at, analyze elements of an ECG rhythm strip, ventricular as well as atrial rate, ventricular and atrial rhythm, including conduction disturbances, identify ECG criteria, causes, and management of several different dysrhythmias, compare different types of pacemakers, their uses, possible complications, and nursing implications, describe the key components of using a defibrillator, and identify the purpose of an implantable cardioverter, defibrillator, the types available, and the nursing implications. Cardiac disorders of the formation or conduction of the electrical impulse within the heart is considered a dysrhythmia, and it causes an irregularity in the heart rate, the heart rhythm, or it can at times be both. They are identified by site of origin as well as mechanism of formation or conduction involved. And then the treatment will depend on the frequency of the dysrhythmia as well as the severity of the symptoms. Just a review, electrical conduction starts in the SA node and is responsible for stimulating the pacing of the cardiac muscle. So it's often called the pacemaker of the heart. The impulse will then travel through the atria to the AV node or atrioventricular node. This causes the atria to contract. The contraction will then push the blood through to where it needs to go, depending on if it's the left or the right. The impulse then travels through the bundle of His to the right and left bundle branches and then down to the Purkinje fibers, which are located in the ventricular muscle. Electrical stimulation is called depolarization and mechanical contraction is called systole. So that's where you get your systole and diastole or systolic and diastolic pressures. Electrical relaxation is called repolarization, and mechanical relaxation is called dystole. Each lead for your ECG will show the electrical activity of that specific area of the heart, and this can help determine the area of the heart that is affected. And so you can get a 3-lead, 5-lead, 12-lead EKG or ECG, and depending on where the leads are, it will pick up an electrical impulse in a different area. As far as ECG placement, you can look at the picture and it tells you where to put 1, 2, 3, 4, 5, and then you have right and left arm and right and left leg. Sometimes you'll see them actually put them on the thighs instead of down on the legs. It just depends on how quickly they're trying to get the ECG. Poor adhesion of the probe or the leads can cause artifact, which is irrelevant waveforms. It can also be caused by hair, oil, lotions, and alcohol. So if you clean with alcohol and then put the sticker on, you can get artifact from that. So make sure that you just clean with soap and water if you're trying to clean. The number of leads and electrodes will depend on the type of ECG that's being obtained. Generally, this is something that's ordered by the physician. Continuous monitoring can use anywhere from 2 to 5 leads, depending on what the protocol is and where you're at. A 12-lead ECG will show left ventricular activity. And if you want right-sided heart activity, then you need to make sure the precordial leads are used as well. Okay. When an ECG waveform moves towards the top of the paper, it's called a positive deflection because it's going up. When it moves towards the bottom of the paper, it is a negative deflection, which means you're going down. So you have your basic line. So you have a line, and then you have upward movement like here and downward movement here. So positive or negative deflection. The ECG is composed of waveforms, segments, as well as intervals. So that's just terminology that you'll hear often. The P wave, which is right here, I can circle it, represents the electrical impulse starting in the SA node and spreading through the atria with atrial depolarization. QRS is here, and that's called a complex. So the QRS complex represents the depolarization of the ventricle and the electrical activity of that ventricle. The Q wave itself is the first negative deflection after the P wave. The R is the first positive deflection after the P wave. And then the S is the first negative deflection after the R wave. The T wave specifically represents ventricle muscle depolarization, and it's often referred to as the resting state. So here's T. And that is ventricle muscle depolarization. And then you have the U wave, which is right here. And that represents repolarization of the Purkinje fibers. Sometimes you'll see it on an EKG, but most of the time you really won't see it on the ECG. The PR interval represents the time needed for the sinus node stimulation, atrial depolarization, and conduction through the AV node to occur. So from here, let me erase first. So let's erase all of this. So PR interval, P, oops, a little too far. So this right here. And so that's the time needed. So if you look down here, this is your time. Okay. Each little block is 0.04 seconds. So from the start of the P until the R, that's how much time it takes for SA node stimulation, atrial depolarization, and conduction through the AV node. The ST segment represents early ventricular repolarization, and this is where you look to see if there's cardiac ischemia. So here's your ST. Maybe if I can get my ST. Okay. And then QT interval represents the total time for ventricular depolarization and repolarization. So from Q to T, that's how much time it takes for the ventricles to depolarize and then repolarize. TP interval is isoelectric period, and that's whenever there is no electrical activity detected. The ST segment and the PT interval are compared usually so that you can detect any ST segment changes. So you compare the two to see if there's any kind of change in the ST. If you go from P to P, that interval is used to determine the atrial rate and rhythm. And you go from R to R for the ventricular rate and rhythm. So if you want to know your atrial rate and rhythm, you look from one P to the next P. And for the ventricular, you're going to go from one R to the next R. To determine the atrial heart rate, you take 1500 divided by the number of small boxes between the two P waves. And then the ventricular rate is 1500 divided by the number of small boxes between the R waves, and that will give you your atrial or ventricular rate. Looking here, on the slide, it tells you how to look at an EKG and interpret it, and then also tells you how long you should have for your PR interval, your QRS, and your Q to T. So you can tell if it's abnormal or not. Okay. Normal sinus rhythm, this is what it looks like, and it occurs when electrical impulse starts at a regular rate and rhythm in the SA node, and then it travels through the normal conduction pathway, and there's no irregularities that are seen or abnormalities. So this is what it looks like. You should see P, QRS, and T. Sinus bradycardia. This is when the SA node creates an impulse, but it is slower than a normal rate. So if you say that someone's bradycardic, you're talking about sinus bradycardia. It's caused by lower metabolic needs, vagal stimulation, certain medications, beta blockers. It can also be caused by sinus node dysfunction, increased intracranial pressure, decompensated heart failure, and coronary artery disease. If the bradycardia is unstable and symptomatic, then you're looking more at hypoxemia, so lack of blood flow in the blood. The treatments depend on the cause as well as the symptoms, but if you do have sinus bradycardia that needs to be treated, then you're going to give atropine 0.5 milligrams IV push. You can give that every 3 to 5 minutes until the max dose of 3 milligrams is administered. If the patient is unresponsive to atropine, then they can be put on transcutaneous pacing until you can figure out what is causing it, and the initial cause can be fixed if possible. But if you look, you're still seeing the P, Q, R, S, and T. So you're still seeing a regular rhythm. You just have an abnormal rate with sinus bradycardia. Sinus tachycardia is the opposite of brady. The SA node creates an impulse that is faster than the normal heart rate. It can be caused by physiologic or psychological stress. It can also be caused by medications that stimulate sympathetic response, enhanced automaticity of the SA node, or autonomic dysfunction. Again, treatment will depend on the severity of the symptoms and the cause. Sometimes if you get rid of the cause, then the tachycardia goes away. If sinus tachy is persistent, they can do synchronized cardioversion. You can also try vagal maneuvers to try and slow the heart rate down. You can do the carotid massage, have the patient bear down, do forceful sustained coughing. You can do cold stimulus to the face. You can also give adenosine, and that will help slow the heart rate down, obviously with the physician's order. Sinus arrhythmias occur when the sinus node creates an impulse at an irregular rhythm. The rate will increase with inspiration, and then it will decrease with expiration. So if you look, you notice here, I guess let me see. Okay, so if you're looking at this patient, looks like they're breathing in here, then they're exhaling because you have the slower rate. And then here looks like they're breathing in again because the rate picks up. Generally don't treat this. Atrial dysrhythmias originate in the atria, not in the SA node. So that's why they're called atrial instead of sinus dysrhythmias. A premature atrial complex, or PAC, is an electrical impulse that starts in the atrium before the next normal impulse from the SA node. It can be caused by caffeine, alcohol, nicotine, a stretched atrial myocardium, anxiety can cause it, hypokalemia, hypermetabolic states, atrial ischemia or injury, or atrial infarction as well. PAC is often seen with tachycardia. The patient will have an atrial radial pulse deficit. So if you listen to the apex of the heart and then you feel for the radial at the same time, you'll notice that there's a deficit between the two. The patient might complain of their heart skipping a beat. Treatment, generally identify and treat the underlying cause. But if you look, it's like more like a mountain. But do you see right here? I know they circled it. I'm going to circle it too. So you have your normal wave P, Q, R, S, T, S. Come on. T, and hiccup. It's like a hiccup. And then it's normal. And then there's this long pause where it tries to reset. Then you have atrial flutter, and that's down here. With atrial flutter, conduction defect in the atrium causes a rapid, regular atrial impulse between 250 to 400 beats per minute. Not all of the atrial impulses are sent to the ventricle because there's a block at the AV node. Risk factors for atrial flutter will mimic those of AFib or mirror them. Excuse me. The patient will complain of chest pain. They'll be short of breath. They'll have a low blood pressure. And this is something that's serious. AFib and aflutter are both serious conditions that would be treated. Treatment, you can try vasovagal maneuvers. The physician can order adenosine IV push. You can do electrical cardioversion. AFib is the most common sustained dysrhythmia. It causes electrical changes in the atrial myocardium and structural remodeling of the electrical circuit, and it also causes fibrosis. The abnormalities in the atria cause rapid, disorganized, uncoordinated twitching of the atrial musculature. And so you can have many different types of treatments. The patients are at increased risk for heart failure, MI, as well as embolytic events. The patient will be asymptomatic, or if it is a very high rate for the heart rate, then they'll have palpitations, complain of palpitations or fluttering in their chest. They can also have clinical manifestations of heart failure, and AFib can lead to mitral valve dysfunction, mitral regurgitation, intraventricular conduction delays, and dilated ventricular cardiomyopathy. The treatment for this, one of the options is the Maze procedure, and small transmural incisions are made throughout the atria. And this forms scar tissue that prevents re-entry conduction of the electrical impulse. So you're trying to stop the extra impulses within the atria. Okay. So scar formation is good. You want to see that. It means that the Maze procedure was successful. They can also do catheter ablation therapy, which will again form scars They can do cardioversion, and then anticoagulation therapy is something that patients with AFib or afibrillation will be put on, and that's because they're at increased risk for getting some sort of emboli. As far as ventricular dysrhythmias, you can have PVCs, and that is your first one here. A PVC is an impulse that starts in the ventricle. It is conducted through the ventricles before the next normal sinus impulse. Risk factors are caffeine, nicotine, and alcohol. You can also see PVCs if a patient experiences an MI, if there's increased workload on the heart, if they're on digoxin and they have digitalis toxicity, so they have too much digoxin in their blood, hypoxia, acidosis, electrolyte imbalance like hypokalemia. PVCs can be singular. They can also have bigeminy or trigeminy or even quadrigeminy, and that just means that instead of having one PVC, they have multiple PVCs together. So bi would be 2, tri 3, quad is 4. They can be asymptomatic. They can also complain of it feeling like their heart is skipping a beat, and the treatment is just to treat the underlying cause. So with PVCs, you see the dips. So that's your premature contraction. And then you generally have some kind of a pause, and that's why they feel like their heart's skipping a beat. And so this one would be singular. There's only one. Sometimes you can have multiple. So you can have like this dip, and then it dips again before it finishes out. Ventricular tachycardia, or VTAC, is when there are 3 or more PVCs in a row at a rate greater than 100 beats per minute. VTAC is an emergency, and the patient nearly always is unresponsive, and they'll also be pulseless because the heart is not functioning. Treatment depends on if the rhythm is monomorphic, which means that there is a consistent QRS complex. If it's polymorphic, which means that the QRS shape is varying, or if there's a prolonged QT interval prior to VTAC. So they're going to look back if they can, if they were put on continuous tele, to see what was going on before the VTAC started. They're also going to look at comorbidities. And VTAC, again, is an emergency and needs to be treated immediately. Okay. Torsade de Pointes is a polymorphic VTAC that's preceded by a prolonged QT interval. And treatment can be anything from monitoring to antiarrhythmic medications. They can do pacing, they can do direct cardioversion, or they can do defibrillation. Anyone who has any type of VTAC and they're unconscious and they have no pulse is treated the same as VFib. So they will do immediate defibrillation, then they'll code the patient because they don't have a pulse. Okay. VFib is down on the bottom left. It's the most common dysrhythmia in patients in cardiac arrest. It's a rapid disorganized ventricular rhythm. It causes ineffective quivering of the ventricle, and there's no atrial activity that you can see on the ECG. The most common cause is coronary artery disease that results in a subsequent MI. And they would need to be defibrillated. Ventricular asystole, which is known as a flat line, is an absent QRS complex. It's confirmed in 2 different leads, as well as not being able to find any kind of heartbeat, no palpable pulse, no respirations. Without immediate treatment, it leads to death because they have no respiratory rate. They're not breathing and they also have no pulse, so their heart's not functioning. Treatment would be high quality CPR, trying to treat the underlying cause. Look for hypovolemia, acid-base imbalance, hypoxia, hypo or hyperglycemia, hypo or hyperkalemia, hyperthermia, trauma, toxin, cardiac tamponade, tension pneumothorax, or some kind of a thrombus. So you'd perform CPR and see if you can find a cause and then try to treat the cause as well. Okay. As far as conduction abnormalities, AV blocks occur when the conduction of the impulse through the AV node or bundle of His is decreased or completely stopped. It can be caused by medications, Lyme disease, myocardial infarction, valvular disorders, cardiomyopathy, endocarditis, or myocarditis. It can be temporary, it can resolve on its own, or it can be permanent, and it can require pacing. So there's all different ends of that spectrum. Clinical manifestations do depend on the degree of the block. In a first-degree block, all the atrial impulses are conducted through the AV node into the ventricle, but they're done at a rate slower than normal. In a second-degree AV block type 1, there is a repeating pattern in which all but one of the series of atrial impulses are conducted through the AV node into the ventricles. Each impulse takes a longer time for conduction than the one before until one impulse is completely blocked. A second-degree AV block type 2 is when only some of the atrial impulses are conducted through the AV node into the ventricles. And that's here, hold on. So this is type 1, or first degree. Second degree type 1. Second degree type 2. And a third degree, no atrial impulse is conducted through the AV node into the ventricle. As a result, there are impulses that are stimulating the atria and impulses that stimulate the ventricles. Therefore, there are more P waves and QRS complexes because of the difference in the SA node rate of the heart. Okay, so third degree is here. As far as what the nurse needs to do, look at possible causes, contributing factors, and how the dysrhythmia is affecting the heart's ability to pump an adequate blood volume. If cardiac output is reduced, the amount of oxygen reaching the tissues and vital organs will be diminished, so you need to assess for that. You're going to look for syncope, lightheadedness, dizziness, palpitations, chest discomfort, as well as fatigue. Ask the patient about previous occurrences of decreased cardiac output. You can also look back in their history in their chart, especially if they're unresponsive or confused. Look at all the medications that they are prescribed, as well as their adherence to the medications, and then consider the side effects of the medications, potential contraindications, and adverse reactions, just in case they're on two medications that do not interact well with one another. You're going to look at their lab results, complete a psychosocial assessment, and then do a physical assessment. Look at changes in their level of consciousness, signs of fluid retention, which can be cardiac related. Look at the skin color and then touch the skin for temperature. Check their peripheral pulses. Are they strong? Are they weak? Are they bounding? Look for edema. When you listen to the heart, you're going to listen for murmurs or extra heart sounds. So do they have S3 or S4? Look at their blood pressure as well as the difference between the systolic and diastolic to see if it's widened or if it's shortened, because the pulse pressure is going to be important as well. As far as interventions, monitor their blood pressure, monitor their pulse rate as well as rhythm, their rate and depth of respirations, listen to their breath sounds, because if they are going into heart failure, then you might hear crackles. For lightheadedness, dizziness, and fainting, you're going to put them on precautions for falls. You'll do a 12-lead ECG, have them on continuous telemetry or continuous cardiac monitoring. It's your job to analyze rhythm strips. Even if you do have a teletech, it's still your job to look at the rhythm strips for the patients that you have. Educate your patients on signs and symptoms of the disease itself, the medications that they're taking. You're going to do all the med teaching as far as why they're taking it, when they should take it, some signs and symptoms, side effects to look for that would be expected, and then adverse reactions, things they need to let the doctor know about right away. If they need to check blood pressure or pulse before they take their medication, then they need to know about that as well. They need to know when they need to seek help, what they need to report. They should avoid caffeine, they should avoid smoking, and they should avoid alcohol, and that needs to be taught as well. If your patient is having an episode of dysrhythmia, especially where they're symptomatic, you want to stay with the patient. Don't leave the patient alone just in case they do take a turn for the worse. If you notice an ECG change, if the patient needs to get up, you need to be there with them. If they're having an episode, it's best if they don't get up and move around, because that can make it worse. And if you do notice an ECG change, you need to let the physician know, especially if they're symptomatic. You also might need to call rapid response. If they become unconscious and pulseless, then you would call a code. Okay. If you are inpatient, sending them home, then you need to do a lot of education before you discharge them. If you are a home care nurse that is going out to see them after they've been discharged with a diagnosis of a dysrhythmia, then you need to follow up and make sure that they know how to take care of themselves at home. If they're supposed to take their blood pressure, then you need to have them show you that they know how to use the machine. If it's a pulse, then they need to show you that they know how to take their own pulse, and they know who to call when, and it's a good idea to have those phone numbers right by a phone, or if they have a cell phone, actually programmed into the cell phone. It's also good to have it, even if they have it programmed in their cell phone, to have it on the refrigerator or somewhere that someone else can see, just in case they're not able to make the call themselves. You can talk to them about any comorbidities and how that affects their condition. You can get a social work out if they aren't able to care for themselves, or if you have concerns about them going home, especially if there's no one that can help them. And they can also help them with making sure they get the right medications. They can afford any type of home monitoring systems that they might need. And social work can help with a lot of that. Okay. There are different types of pacemakers. We'll talk about that. And then we'll talk about cardioversion, defibrillation. Cardioversion, the nurse can be involved in. The patient is sometimes awake, sometimes they're given like a sedative hypnotic because it can be painful, but they a lot of times are actually going to be awake if you're doing a cardioversion. Defibrillation, most of the time they're unconscious and they're not breathing and don't have a pulse, and that's why you're doing defibrillation. As far as cardioversion and defibrillation, a defibrillator can be used for both cardioversion as well as defibrillation. Both are used to treat tachydysrhythmias, and they're used by delivering electrical current to depolarize the myocardial cells, allowing for the SA node to recapture its role during repolarization. So it's almost like a reset. Defibrillation uses a higher electrical voltage than cardioversion. So when you're looking at the defibrillator itself, if you're defibrillating, you want the synchronized mode to be off. If you're cardioverting, you use a lower electrical voltage and you want the synchronization mode to be on. So cardioverting, you do want to synchronize because you're wanting to synchronize those beats. Defibrillation, you want it off. You're doing a complete reset, which is why you have that higher voltage. So you're trying to stop the actual electrical conduction that's going on so that the body can pick up what it's supposed to be doing and the SA node can start working sufficiently again. Okay. As far as paddle placement, you can do both in the front or in anterior, posterior. When using both paddles and pads, the nurse is responsible for the safe use of the devices. So they have pads now a lot of times instead of using the paddles. Either way, you're responsible for the safe use of the device. As part of the code team, there will be a nurse that is responsible for that. There has to be good contact between the paddles or pads as well as to the patient's skin, and that is because you don't want to have any arcing. If you have arcing, you can actually shock someone that's nearby, and then the patient isn't getting the voltage that they need. If you're using paddles, you need to apply about 25 pounds of pressure so that you make sure you have good contact with the skin. No one can be in contact with the patient or anything that's touching the patient when the current is being discharged. So you want to make sure when you say I'm clear, you're clear, everyone's clear, you're looking at the patient and everyone else, and you're looking at the bed or the floor or whatever the patient is touching to make sure that everyone's clear so that they don't get a current that goes through the patient like into the bed. If you shock someone else, then you can have two patients that you're having to deal with. Okay. Before you discharge any kind of current, so before you hit the buttons on the panel or you hit the shock on the defibrillator, you need to make sure that the patient and everyone is clear of the patient. You do that 3 times. When you're charging, that's the first time that you're going to check. When it's fully charged, you're going to check again. And then before you hit the button, you're going to check a 3rd time. Again, if you're defibrillating, synchronized mode needs to be turned off. Otherwise, you will not give the correct voltage. Okay. Pacemakers, this is something that's more permanent, and it stimulates the heart muscle. Pacemakers consist of 2 components. They have an electrical pulse generator, and then they have the electrodes. The generator contains the circuitry as well as the batteries, and then the electrodes are actually threaded through the right atrium and ventricle, or they could be sutured to the outside of the heart, but they're the part of the pacemaker that's in direct contact with the heart itself. The battery will alert when it's due to be changed, and it can be changed under a local anesthetic, so it's not as significant a procedure as the initial insertion of the pacemaker. As a nurse, you need to make sure that you monitor a pacemaker for malfunction, as well as battery failure. And that's just an example of where the pacemaker would be. So here, they have it on their right chest. You can see it on the right or the left. So his is on the right side of his chest. You can see it over here as well. It just kind of depends on where it would best fit, given the patient and their situation. Okay, and then they thread it down through atria and ventricle. There are complications because a pacemaker is a foreign object that is surgically inserted into the body. The most common complication is in the initial hours after placement, and this would be dislodgement of the lead. An ECG will detect pacemaker malfunction. The nurse needs to ensure documentation of the pacemaker model, the type of generator, the date and time of insertion, the location of the pulse generator, the stimulation threshold, and the pacemaker settings. And they just need to make sure that's in the chart. The surgeon will document that there's usually a sticker that can be placed in the chart whenever we had paper charts. Otherwise, you might have to put all that information in. But the information needs to be known so that everyone knows what type of pacemaker it is. If they switch physicians, they move out of town, they need to find a new cardiologist. All that information is important. And also we need to be able to track if there's any kind of recall or malfunction that's known with the device itself. Implantable cardioverter defibrillators, or ICDs. This is recommended for patients who have been diagnosed with non-ischemic dilated cardiomyopathy for at least 9 months. They have a functional NYHA class 2 or 3 heart failure. The ICD is a device that detects and terminates life-threatening episodes of ventricular tachycardia and VFib. So it actually will detect whenever there's ventricular issues, and it will send an internal shock to try and reset the heart so that it doesn't stop. And if you look, it looks a lot like a pacemaker. Again, it can be put in either one, but it also gets fed through and followed down from the atria to the ventricle. If these patients are skinny, you can actually see from the outside. If they're bigger, you can feel where the placement is. Initially, you'll see the incision site. Sometimes that can fade. It just depends on when it was placed. And you'll want to note on which side that they have the pacemaker, what type of pacemaker. So if you have a patient who has a pacemaker that's older, you can ask them information about it if they know if it's a pacemaker for pacing or if it's for defibrillation, that you can actually discuss that with them. They will know. They will be very well educated in the pacemaker that they have and what it does. They'll have extensive conversations with the cardiologist before it's placed to see if it's something that is what they need or not. Okay. As far as education, after the pacemaker is inserted, the patient will have limited use of the side of the pacemaker placement. So if it's the right side, they'll have limited use of their right arm. If it's on the left side of the chest, they'll have limited use of their left arm. They need to have in-person follow-up visits with the cardiologist, and all of this is discussed by the cardiologist with the patient, but you need to make sure and reinforce the importance of them doing their follow-ups and actually going and having the follow-ups. It has to be in person so that they can check the pacemaker itself. They do have ECG recordings with phone apps and different at-home devices that can be used. The typical follow-up schedule is every 2 weeks for the first month, and then every 4 to 8 weeks for the next 3 years. And then after that, then it just depends on the cardiologist and what they need. There is also something that they can do on the phone once their initial visits are done. And they're just doing their maintenance. But in the beginning, they really need to see the physician so that everything can be looked at and they can get readings from different devices and make sure that the threshold is the way it should be.